Our next speaker is Heather Murgatroyd. Heather has been a respiratory therapist since 1994. In 2001, she cross-trained in sleep and worked in sleep until 2018. She also worked in the pulmonary function lab for 6.5 years. In 2019, she took her first job as clinical specialist for Methafarm. As a clinical specialist, Heather has developed and provided continuing education programs throughout North, Central, and South America. She also trains new customers and provides clinical feedback on product development. Please welcome Heather Murgatroyd as she presents Is It Asthma? Her speech is sponsored by Methafarm.
Okay, I hope you can see my screen and you can hear me okay?
Yes, we can hear you. Thank you.
Okay, good. Okay, what an informative presentation that last one was. I'm so grateful that I had the opportunity to listen. As stated, my name is Heather Murgatroyd and I am a respiratory therapist. Per the AARC, I also need to share with you that I am a clinical specialist for Methafarm. Methafarm provides provocholine, which is the only FDA-approved methylcholine chloride for the methylcholine challenge in the United States. And we are also the distributors of Aerodol. And through this presentation, I will mention both of these products. However, I'm not discussing them specifically. I am discussing them in context of bronchoprovocation testing and the diagnosis of asthma. So during this presentation at the end, I hope you'll be able to discuss the prevalence and economic burden of asthma in the United States. We'll talk about the common signs and symptoms, which is a lot of review, but it's still important to revisit them. And we'll talk about the phenotype of asthma as well. We'll talk about disease states that mimic asthma and why it's important that we keep them in our mind in the diagnostic process. And then we'll also talk about the objective tests that are available to diagnose asthma. And then we'll wrap up with a little bit of a discussion on medications for asthma. So according to the World Health Organization and GINA, about 235 million people worldwide have asthma. So why is this important to us? Well, people come here for visits, they move here, and when they're here, they're part of our healthcare system. So we need to take care of them. So recognizing that it is a worldwide problem, that the prevalence is highest among children globally, and that it affects, as it does here, middle to lower income families the most throughout the world. So within the United States, there are about 25 million Americans with asthma. So that's about 1 in 13. And if you've been a therapist for any length of time, I call myself a seasoned therapist, or even if you've been in the field, not so long, you may feel like the asthma numbers are increasing and that it's becoming more complex, and you are correct. We have seen the numbers of asthma increasing since about the 1980s. So just throwing this question out there, how many people do you think die every day in the United States from an asthma exacerbation? 5, 10, 20, or 25? About 10 people die every day from an asthma exacerbation. So if you're a respiratory therapist for any length of time, you will be involved in that scenario. And it's hard because we know that asthma is manageable. So we just have to do a better job. Asthma is a chronic disease. It affects our patients' quality of life, right? Productivity at work and school. Our asthmatic patients utilize more healthcare resources as far as tests, medications, dollars than our non-asthmatic patients, and they also have higher mortality. So when we look about how much does asthma cost, this information from this paper, The Economic Burden of Asthma in the United States from 2008 to 2013. What they did, where they gathered this information, was from the Medical Expenditure Panel survey. So they gather information from non-institutionalized people in the United States. So they sample households for each year, asking if they've had a medical or a pharmaceutical encounter or claim associated with asthma. So for this particular paper, about 213, almost 214,000 people were pooled. 10,200 plus had a treated asthma claim or pharmaceutical encounter. The average cost was about $3,200 in 2015 dollars, or $50 billion. And you can see the breakdown of where those costs were put out, and prescription medication being the most expensive. Asthma is expensive. We need to make sure that our patients have the right diagnosis before we start just sort of empirically treating their symptoms. And I'm gonna kind of hone in on that as I go through this presentation. So just kind of further breaking things down, we see missed work and school days were about $3 billion. Asthma-related mortality, about $29 billion. Again, that medical cost of $50 billion. So it's $82 billion for our asthmatic population. And this is where I typically will stop and just say to the audience, thank you for being a respiratory therapist. If you think about the patient populations that we work with on a day-to-day basis, they are incredibly complex. None of them are exactly the same. And they're all very expensive. If you think about our COPD patients, our asthma patients, our pulmonary fibrosis patients, cystic fibrosis patients, right? We deal with really challenging patient populations. So thank you for taking up the challenge and becoming a respiratory therapist. So what impacts the costs of asthma? Why is it so expensive? Well, those new treatment options, all those new medications that we see coming out all the time for our asthmatic patients cost money. The research costs money. The testing costs money. And the development, the marketing of them costs money. Federal and state policies and pricing varies depending on where you live. Reimbursement varies depending on where you live. We have differences in our healthcare market. Some of you may work in rural areas where you see your patients have to travel long distances to have testing done or to see a specialist. I've worked with hospitals and labs where they don't have specialists such as pulmonologists or asthma allergy docs or infectious disease docs. So their patients either have to drive really far or the specialist comes in once a month to work with the patients. So the healthcare market that our patients live in varies, and that impacts cost. The effectiveness of your asthma control programs impacts the cost. It's not enough to just diagnose your patient with asthma and then send them on their way. We have to make sure that once they are diagnosed, that they have follow-up, that they understand the medications that they're on, that they have the right follow-up testing if necessary. Having good, strong asthma control programs can help decrease the costs because it helps decrease the exacerbations that our patients have and the variety of medications they may have to work through. So when we look at the economic burden of asthma, if you've thought over time there are more asthmatic patients, they're getting more expensive, you're absolutely right. So the first study of the economic burden of asthma was done back in 1990, and it was about $6.2 billion at that time. In 2007, we saw 37 billion. In 2011, we see 56 billion. And then again, 2015, we have that $80 billion. So yes, asthma is getting more and more expensive, and it is becoming more and more complex. What I like in this paper is that it doesn't just throw things at you, it breaks down the costs, and again, supports that the medical costs of our asthmatic patients versus our non-asthmatic patients are greater, about double. But what I think you could utilize this type of information for is going back to that asthma control program. I think for respiratory therapists, a really good opportunity lies in the role of the asthma educator. And so some of you may already have that credential, and some of you may work in hospitals where they have an asthma education program. So previous to this role, I worked with the COPD. I worked in the COPD world. And so I interacted with the COPD navigators quite a bit. And I see that expanding into the asthma world, having respiratory therapists dedicated to educating and following up with our asthmatic patients. We've seen that it's beneficial and helpful for our COPD patients. I would imagine that it would be similar for our asthma patients. And so rather than just developing a program, you can take a paper such as this, where it breaks down your patients into subgroups and shows you where the medical costs lie. So here is an example of the adults and Medicare patients and the poor. It goes even further than that. This is just a couple of examples of where they're showing you the costs associated with asthma. But if you're developing a program for your hospital, you could look at this and you could say, well, we have this patient population or that patient population. Therefore, it would be best to target our marketing and our efforts towards these patients so that maybe we can help minimize or decrease their exacerbations. We can help decrease their medical expenditures by focusing on them. So I think that information like this from this type of paper, if you're interested in developing a program like that, could be very helpful. Looking at that economic burden of asthma, we know absenteeism is an issue. Kiddos with asthma miss more school days. So this is not only 2.3, it's additional school days. And then we know adults with asthma miss more days of work. And then also included in here, but not on this slide, is the parents of the kiddos. When a child is ill and staying home, somebody has to stay home with that child. So that's an additional economic burden, having to take off work to stay home with your kiddo. Within this study, what was not really looked at as far as putting a dollar amount on it was transportation. So looking at gas, parking, if you have to travel an hour or 2 hours to see a specialist or have a test done, your appointment wait time. If you think about how much you make an hour as a respiratory therapist, have you ever had to wait for half an hour to see a physician or have a test? Have you ever had to wait 45 minutes, maybe even an hour? If you think about how much you would be making in that same time frame, you could see how that becomes burdensome. Pre-absenteeism. Now, I would never ask people to raise their hand, but pre-absenteeism is something that I think most of us can say we've done at least once or twice in our career, where you're going to work, but you're not really fully functional because you don't feel good. And then just kind of general pain and suffering was also not looked at. So this begs the question of, is it asthma? Is what our patient is, being treated for, is it really asthma? So what we see, and therapists who've been around for a while will probably agree with, is that asthma is a complex disease. It's made up of a lot of variants with underlying pathophysiologies. And so we still have some limited knowledge about the mechanisms of the subgroups to really understand and treat optimally asthma. And so what we're seeing now, though, is that asthma is not simply asthma anymore. It is, we're seeing phenotyping of asthma. And so the phenotyping is, what does it look like? How does it manifest? If we can figure out the mechanics behind why one phenotype of asthma looks, say exercise-induced bronchoconstriction, how does that manifest differently than, say, allergic asthma? And maybe we'll target our therapies for our asthmatic patients based more on the phenotyping in the future versus just a blanket they have asthma. So I think we're going to see some really interesting things in the asthma world, looking at the phenotyping and genotyping and endotyping, which is the mechanism behind the manifestation of the phenotype as we move forward. And I think we're going to start seeing really targeted and precision treatment and therapies for our specific phenotypes. So looking at, then this wheel is not complete as far as the asthma phenotypes, but you can see the breakout. So exercise-induced bronchoconstriction, which I am going to talk about a little bit more in my next presentation, has very different triggers than, say, allergic asthma versus occupational asthma. And we see occupational asthma oftentimes with our environmental service workers in the hospital or in the hospitality world, where they're exposed to chemicals and dust and things in their workplace. And that's when they have symptoms and signs and symptoms. But would we treat them differently, or should we treat them differently than we do someone who has EIB? You know, these are questions that are starting to get answered and looked at. And I think that makes it a very exciting time to be working in the asthma world. This takes you back to your first probably couple of weeks in your respiratory program, talking about the signs and symptoms of asthma. And we all know them, and we're all very, very familiar with them. But if I tell you that the patient is experiencing shortness of breath or difficulty breathing, dry cough, wheezing, chest pain, does that automatically mean they have asthma? No, it doesn't. They could have any number of things, right? What else causes wheezing? Well, we hear wheezing with CHF, might be a different reason, but we still hear it. Do we see difficulty breathing with COPD? Absolutely. This is kind of setting the stage to why diagnostic testing is so essential and why our guidelines tell us that we need to do spirometry and diagnostic testing on our patients before we give them an asthma diagnosis. What we find through the research, though, however, is that our asthmatic patients are still often diagnosed and treated based on symptoms alone. And if those symptoms are wheezing, shortness of breath, and cough, we know that that can mean a whole lot of other things, not just asthma. And unfortunately, we're not getting our patients their diagnoses confirmed with objective testing. So kind of to that point, this is a really interesting study. It was published in JAMA in 2017. It's a Canadian study. It was a multi-center study. And what they did is they looked at patients who had a current diagnosis of asthma. So they've been diagnosed within the last 5 years using the current methodology. 710 patients were selected to participate, about 613 completed the study. When they looked at they did chart reviews, and then they did all kinds of testing, including spirometry and bronchoprovocation testing. 56% of the patients did not have objective testing as part of their initial diagnosis. They did not have objective testing. At the end of the study, after being reevaluated, 203 of the 613 patients did not have asthma, but they were being treated as though they had asthma. What did they have? This is a list of the different diagnoses that the patients had. Do they wheeze? Sure. Maybe they cough? Sure. Maybe they have shortness of breath? Absolutely. What's the gold standard treatment for vocal cord dysfunction or vocal cord dysplasia? It's speech therapy, not a bronchodilator, speech therapy. But if you've seen someone who's having an episode of vocal cord dysfunction, it can look very much like asthma, right? It can look like shortness of breath, coughing, wheezing, chest tightness, but the bronchodilator is not going to help them. So this, again, is emphasizing why objective testing is so important. So what are the different tests? I am going to talk about them. Why do we use them? Because someone's spirometry does not give us all the answers. Spirometry is the test that we start with. And if it doesn't give us the information that we need, there are additional tests available for patients to really make sure we're treating them for the right condition. One of the questions is, should we use objective testing to monitor patients and to step down medications? Absolutely. Spirometry should not be a one and done. Some of the bronchoprovocation tests can be used to monitor patients or to help step down medications. So there is a way to utilize these tests ongoing in our asthma management programs. So we're just going to start real quick with spirometry. Even if you are not working in the pulmonary function lab, I'm quite sure that you're familiar with spirometry. You may do bedside screening with your patients, or you may have had, we've all had exposure to spirometry. So basically, our guidelines tell us that our patients need to have spirometry with and without bronchodilator prior to being diagnosed with asthma. Spirometry is widely available. It is reimbursed by Medicare, Medicaid, and all the commercial insurance company, all the commercial insurances. So why isn't it being done consistently? I don't know. We have that question posed to us often when we do this presentation. And using we, because I have a co-clinical specialist that I work with. We hear that a lot. I don't know why, because there's still, I guess, a confidence that we can diagnose asthma just based on symptoms alone. But if you think back to that study that I just talked about, we really can't. So spirometry, again, widely available. If you are a therapist and you have a patient that you know in the hospital who tells you that they have asthma, but they've never had spirometry, if you ask them if they've ever had a pulmonary function test and they tell you no, or they haven't had one in 10 years, make a note, advocate for that patient, get the test done. So some of the objective tests that are available beyond spirometry. So we use these objective tests when the patient's spirometry does not give us a complete answer. They're reporting asthma-like symptoms, however, their spirometry is normal. You don't have to just stop there. You have the objective tests available to dive deeper, to really figure out what's going on with the patient. So there are two types or two categories of objective testing. There's direct challenge tests and there are indirect challenge tests. I'm not going to dive very deeply into the indirect challenge tests during this presentation because I have another presentation that I'm going to talk about them, but I'll touch on them during this presentation. So the direct challenge tests that are available, the direct challenge tests actually work directly on the smooth muscles of the lungs. So in reactive airways, in responsive lungs, you will see a response to the direct challenge test. Normal non-reactive lungs do not have a response. The direct challenge test's strength lies in ruling out asthma. So the methacholine challenge test, if you work in a pulmonary function lab, or you may recall this from school, we see the methacholine challenge test ordered on military recruits who have a history of either asthma or wheezing or hyperresponsiveness, something in their chart to indicate they have reactive airways from childhood. We see a methacholine challenge test ordered for those recruits prior to enlisting in the service, and it needs to be negative. Histamine is very much like methacholine. However, it is not a licensed medical product in the United States, but it is used in epidemiological studies and research. So it is, again, a direct challenge test, works on the smooth muscles of the lungs. The indirect challenge tests work a little bit differently than the direct challenge tests in that they cause the inflammatory mediators to be released in the lungs, which then cause hyperresponsiveness in reactive airways. So the methacholine challenge test, and full disclosure, my company provides provocholine, which is the only FDA approved methylcholine chloride in the United States. So just to get that out of the way, basically methacholine is given to your patient through a nebulizer. They breathe on the nebulizer for a period of time. And then afterwards, we monitor their FEV1. So for those of you who are not in the pulmonary function lab, the FEV1 is the forced expiratory volume in the first second. So when you're doing spirometry, the patient takes that big deep breath in and then they blast out and they keep blowing out, keep blowing out, keep blowing out, deep breath in. The FEV1 is that first blast out, the first second of that blasted exhalation. We're monitoring that during the methacholine challenge test. If there is a drop of 20% or greater from the patient's baseline FEV1, that's a positive test. And it's absolutely possible to have positive methacholine challenges. However, the strength of methacholine lies in ruling out. It is a very sensitive test in that it does not have very many false negative tests. If you have a positive methacholine challenge, you can take that information, or the physician can take that information in combination with the patient's signs and symptoms and history to make that asthma diagnosis. However, again, the strength of methacholine is in ruling out asthma. It is reimbursed um, by all the commercial insurance companies and Medicare and Medicaid. It is an underutilized test. All of the bronchoprovocation tests are underutilized. Methacholine is. Right now, there are labs that are not doing bronchoprovocation testing. If you are in a pulmonary function lab and you are questioning what tests that should you or should you not do, there is information available to help guide you as to when you can introduce or start to bring back various testing in the pulmonary function lab. Histamine, as I said, is not a licensed product. It's delivered the same as methacholine through a nebulizer. You start at a low dose, you monitor the patient's FEV1 after each dose is given. If they don't drop greater than 20%, you give them the next highest dose. So histamine and methacholine are both cumulative tests. We're building the concentration of these agents in the patient's lungs, monitoring their spirometry, monitoring their FEV1 to see if we see a drop from their baseline. Histamine, just like methacholine, its strength is ruling out. But again, like I said, we see it used in studies and research in the United States. So moving into the indirect bronchial challenge test, I'm not going to dive too deep into these because I'm going to talk about them again. Just know that the exercise challenge test is basically the one it's the most utilized indirect bronchial challenge test that we have in the United States. You can use a bike or a treadmill. There are labs that do have patients run up and down stairs. I have had a couple of labs who have had patients run outside, which actually is kind of ideal, except you just can't. How do you really monitor someone when they're free running? But when you bring them into the lab, you take away any of the environmental impacts you might have if the patient does an outside activity where they're having signs and symptoms. But you're monitoring their FEV1 after you have them perform a certain exercise to see if there's any drops, to see if they're responding to the exercise or the exertion. There is reimbursement for the exercise challenge test. Eucapnic voluntary hyperventilation. This is an accepted surrogate test for the exercise challenge test. We're looking for a 10% drop in their FEV1. And we have them do an MVV maneuver, which is a maximum voluntary ventilation maneuver. So deep rapid breathing for a period of time, and then we're monitoring their FEV1. This is a tricky test because it requires really, really good coaching. I think it's safe to say that all of the bronchoprovocation tests need to be performed by respiratory therapists who have been doing pulmonary function for a period of time, because coaching is really essential. Coaching is really important. Good coaching is essential for all pulmonary function testing, but for the bronchial challenge tests, you really want to make sure you're getting the best effort out of your patient. So you should be an experienced pulmonary function therapist when you're starting to do the bronchoprovocation testing. There is reimbursement for the eucapnic voluntary hyperventilation test, but it is not widely used. And I'll talk again more about it in the next presentation. Cold air challenge is not widely utilized either. You don't have to have cold air to respond to a bronchoprovocation test. However, when we see cold air added, oftentimes the symptoms occur faster than they do with just kind of ambient air. There is reimbursement for the cold air challenge as well. It does require some additional equipment. You need to have a cooling element that cools the air down that the patient is breathing to 14 degrees to -4 degrees Fahrenheit. So pretty cold air that the patient's breathing when they do the cold air challenge. Mannitol, and again, full disclosure, my company distributes Aerodol, which is dry powder mannitol in the United States and Canada. It is delivered through a dry powder inhaler. Sometimes respiratory therapists look at me funny when I bring up mannitol because they think back to ICU and patients who have a head injury. We see mannitol used to help decrease intracranial pressure through a drip. Same mannitol, just delivered in a different way to a different area of the body. So this is for the lungs, kind of drying things out in the lungs. It is an accepted surrogate test for the exercise challenge, and there is reimbursement for it. And I'll go into more detail in the next presentation on this test. Impulse oscillometry is not a bronchoprovocation test, but I think it is it's a really, really great test to have available. And some pulmonary function labs have it, and a lot of them don't. But basically what this test does is it measures the resistance and the reactance using different sound wave frequencies. So the patient is just breathing on a circuit. There's no exertion, they're just normal tidal breathing. And again, those sound waves of varying frequencies are superimposed over their tidal breathing. What I love about this is that there's no real effort for the patient. So they can't really fool the machine with this one, or they can't try to fool the machine. The sound waves can get way down into the tiny, tiny airways, into the periphery, and they can it can show us changes to the patient's periphery, to the patient's airways, even before they're having lots and lots of symptoms. So it allows us to give early diagnosis and monitor the patients ongoing through this test. It's a very interesting test for asthma diagnoses and respiratory pulmonary diagnoses. It's underutilized. There are several companies that have impulse oscillometry devices. I think we need more education on it. I would love to see this as an option for someone who's not able to properly do spirometry. We can still see what's happening with their airways if we have a device like this on hand in the pulmonary function lab. So if you have someone if they're too young, or they have issues with being able to keep a seal for the pulmonary function test, impulse oscillometry could be a very, very nice addition to the pulmonary function lab, and it is reimbursed. FeNO, or fraction exhaled nitric oxide, I see this becoming more and more prevalent, used in the management of our asthma patients. So this is not a diagnostic test, but this is to be used in asthma management. So basically, when there's inflammation present in the lungs, your nitric oxide levels will increase. So the patient exhales into the FeNO device, and it gives us a readout of what their FeNO is. So if you have a patient who is on inhaled corticosteroids, their FeNO levels should be normal. So if you're in the doctor's office, or if you're in the pulmonary lab and you're doing follow-up with the patient and they're on ICS and their FeNO levels are high, that gives you a couple of questions to ask. One, are they on the right are they on the right dose of medication? Are they taking it properly? Do they understand that it is an ongoing medication, right? That it's not just to be used when they're starting to feel symptoms? Or are they taking it at all? So it's helpful in the management, which is, again, so important if we look at how are we going to decrease the cost associated with our asthma patients. We look at the asthma management piece, FeNO has a role there. I see the FeNO devices right now mostly in the doctor's offices and in the clinics, but I do work with some pulmonary function labs that actually have made FeNO part of what they do in the lab. So as far as reimbursement for FeNO, because it's fairly new, the last time I talked with one of the manufacturers of the FeNO device, it was about 85% of the commercial payers were covering it, and Medicare covers it. So the medications, this is kind of overwhelming for us, right? We have to keep track of, and it is sort of alphabet soup. my question to you is, do you teach medication education? Do you ask your patients if they know what medications they're on? Do you watch them use their inhalers? Do you reteach them if their technique is poor? That's really important. If they have it and they're not using it correctly, it's not doing them any good. It's hard to keep track of all the new medications that come out, but that's kind of where we're at. That's important that we know, because if your patient starts talking about medications or something they saw on TV, you want to be able to address whether or not it's really actually for them, because they don't necessarily understand that. We do know that for most of our asthmatic patients, current treatment options offer really good control of their disease. But there is a percentage of patients, 10 to 20%, who do not achieve control with their current standards of care. So these are our severe patients, and our severe persistent asthmatic patients use up most of the resources for asthma, and they're our most expensive patients. So again, kind of if we look at the different phenotypes and endotypes, helping us to target therapies, we can look to the biologics as well, and how are they being used with our asthma patients. The biologics are a really interesting area. If you have the opportunity to listen to physicians speak on the biologics, I would really take advantage of it, because they're all a little bit different. The biologics currently are reserved for our severe persistent asthmatic patients. They are super expensive, but they're working. They're decreasing exacerbations in those severe persistent patients, and they're keeping them out of the ERs, and they're keeping them out of the hospitals. And so, like I was kind of teasing, they all work a little bit differently, and I will leave explaining how they all work to the experts who utilize them. But if you're not familiar with biologics, they're the ones that end with MAB, M-A-B. So omalizumab. I'm very bad at saying medication names. Dilipimab. So let's look at Xolair is the oldest biologic. It's approved for kiddos 6 and up. It's taken by injection. So biologics are delivered either by an injection or by an IV. So you will see patients in infusion centers receiving biologics for their asthma. Nucala is another biologic. It binds to the molecule that stimulates the production of eosinophils. They receive that by injection every 4 weeks. This one was just approved in 2015, good for kids 12 and up. Fasenra, it also binds directly to eosinophils. It's injected every 4 weeks for 3 times, and then it's every 8 weeks. So there's lots of variations in how they're given. It's a routine, it's a regimen, but they're working and they're helping. So it's really exciting. I find the biologics to be really interesting. And I'm hoping in the future, as we learn more and more about the different phenotypes of asthma and the triggers behind them and why they respond the way they do, why patients respond the way they do, maybe there will be a broader use for the biologics, and maybe the cost will come down a little bit. So as far as managing our asthma patients, both GINA and ATS say, stabilize your patients. Get them on the medications that they need to stabilize them so they're not having symptoms, they're not having exacerbations. Then start stepping down with their medications. And we need to do it safely and practically, and asking the patient, well, how are you feeling? That's not really an objective measurement, right? If we say, how are you feeling? And they say fine, and they're short of breath, right? We need to be able to have a measure to see really how they're doing. So that's where, again, those objective tests could be used in the follow-up with these patients. ATS says the same thing, stabilize them and then start to step back on their medication. We step up on medications to stabilize our patients. Once they're stabilized, we can start stepping down. How do we gain better control? Increase awareness for both ourselves and our patients and their caregivers on the asthma guidelines. Help them to identify their signs and symptoms. help to identify future risk, things that situations that they could put themselves in where they might be at risk of an exacerbation. Consequences of overtreatment for our patients, and I would say also undertreatment, it affects their quality of life. They don't do the things they love because they're afraid. Cost of medication for someone who does not have asthma, spending money on inhalers that are not going to help them could be quite frustrating. Our medications have been around for a long time. They're safe, but they do have side effects. The psychological burden, again, making sure they have the right diagnosis, because if they don't and they're taking medications thinking they should feel better and they don't, that's got to be really frustrating for the patients. And then the economic burden, both to the patient and to the healthcare system as a whole. So I'm going to wrap it up. I think my time is almost up. Looking at the costs of asthma, again, that $82 billion, that is a big, big, big number, right? How can you, as the respiratory therapist, both in the PFT lab and on the floor, how can you help to get that number to go down? By advocating for our patients and making sure that they get the tests that are available to ensure that they have the proper diagnosis. So we know, just in summary, asthma has lots of signs and symptoms shared with those other disease states. So just make sure your patient is properly diagnosed or taking the steps to get the proper diagnosis. It is not in our heads. Asthma is growing. The prevalence is growing. Medications are becoming increasingly specific, which is, I think, a good thing. Identifying those phenotypes and the mechanism of action behind the manifestation behind those phenotypes is going to be helpful, I think, in the future to help minimize the exacerbations that our patients are having. And just making sure that we utilize the objective tests can help reduce the number of patients who are misdiagnosed, under and overdiagnosed. And that is, I have that my time is up at 11:30. So we have 3 minutes.
Thank you very much. Thank you very much, Heather. We had a lot of comments about great presentation.
Oh,
and I do happen to have a question or two, and we have time. So the first question I received is, are we missing a huge opportunity to control asthma by not having RT involved in asthma management at home?
I think that would be great. I think that the RTs are underutilized in the education process for our patients. We're the lung experts. I would love to see us involved in the home care follow-up with patients.
Great, thank you. Another question we had, is the term reactive airways interchangeable with asthma?
I don't think wholly, because we can have reactive airways. I'm having an echo. I don't know how to get rid of it. You can see that with other disease states. So I don't feel that it's interchangeable.
Yeah, sorry, when we turn the volume up here, we get an echo. So
Okay.
I really didn't hear if you answered that question. If you did, just say yes and we'll move on.
I said yeah. I don't think that they're interchangeable because you can have reactive airways with other disease states.
Okay, great. Another question is the rising costs due to the cost of medical care itself or a lack of a more personal care and control lifestyle of our patients?
Oh boy, that's a loaded question.
Yeah.
Personally, I think it's probably a combination of both.
Okay. And then one last question is, should you continue with methylcholine challenge if you have a low or abnormal FEV1, say, for instance, 70% of patients predicted? And if so, is a 20% decrease still an indication of asthma?
So, per the guidelines, you can, when you do a methylcholine challenge, you initially start with FVC maneuvers to see where the patient is without having any bronchoprovocation involved. So if their FEV1 at the beginning of the test is 60% or greater than their predicted, you can proceed with the test per the guidelines. Now, your lab may have different guidelines. They may say, we don't want to do it on anybody who's 70%. You know, they have to be 70% or greater with their FEV1 to proceed, or the guidelines state 60%. The 20% holds true. You're looking for a 20% drop for a positive test.
Okay, great. And we do have one or two more questions, but unfortunately we are out of time.
Okay.
And Heather, you received over 50 good jobs, so they really enjoyed your presentation. And hey,
Thank you.
because you enjoyed her presentation so much, she is coming back to us after lunch at 1 o'clock. So everybody go have a great lunch, and we will see you back at 1. Thank you, Heather.
Thanks, Colleen. Have a good lunch.